So tomorrow workshop will gonna held in another building, not this building. Tomorrow workshop will held in the fourth floor of the Srinthila building. And if you guys have any question, you can ask the registration area. Also, you can ask for a map at the registration area also. And I would like to invite all of you to try the ice cream at the Metronic Hall because they would like us to try because it is very tasty. So please try. And the upcoming session is the really interesting topic about QOL, quality of life in cancer pain, and new opioid in cancer pain treatment. Our moderator is the young blood of our pain clinic. She has finished a residency training in anesthesiology and complete a clinical fellowship in our hospital, Siraj Hospital. Even though she is a new generation, he has extensively experience in management of both cancer and non-cancer pain. Also, she had a lot of research and publication in this area. Ladies and gentlemen, please welcome Dr. Surasawadi Wangnamthip.
Thank you very much, Dr. Chupong, for introducing me. Good morning after break. To all participants, my name is Dr. Surasawadi Wangnamthip. I am your moderator for this session. It is my pleasure to welcome you here to the Quality of Life in Cancer Pain with MD Anderson way to make it visible by Dr. Thomas Chai from MD Anderson. As you know, quality of life in cancer pain is very important in pain managing cancer pain. Today, we are very privileged to have Dr. Thomas Chai in this topic. I believe this session will be very useful for all of you. I would like to welcome on the stage Dr. Thomas Chai. Please give a round of applause.
Okay, thank you very much again. Dr. Zinbunyagun asked me if I could talk about pain and symptom assessment tools that we utilize at the hospital at MD Anderson where we practice cancer pain management. So that will be part one of this lecture. And Dr. Zinbunyagun also asked me if I wouldn't mind to talk about a couple of new opioids that are available or will be available in Thailand. So I saved the second half of the lecture to briefly review some new opioids in Thailand. Excuse me one second. Okay, so what I did was I chose select tools for pain and symptom assessment that are used regularly at MD Anderson, including in the pain clinic to discuss. And the following four are the select cancer pain and symptom assessment tools that I'll go over. The first one is the brief pain inventory, otherwise known as a BPI. The second one will be the McGill Pain Questionnaire, the MPQ. The third would be the MD Anderson Symptom Inventory, also known as the MADASI. And then the Edmonton Symptom Assessment System, or the ESAS. I will review an opioid risk stratification tool called the Screener and Opioid Assessment for Patients with Pain, otherwise known as a SOAP. And then, very briefly, performance status tools that the oncologists use to determine prognosis and eligibility for oncologic treatment. And that is a Karnofsky Performance Scale and the ECOG, Eastern Cooperative Oncology Group Performance Scale. And then part 2 of the lecture will be about some new opioids available in Thailand. So in terms of the brief pain inventory, a little bit of the background of the BPI's development. Starting off in the late 1970s, it became evident that cancer pain was often poorly controlled. There were prominent people with cancer pain that were publishing opinion pieces. There was advocacy work by pain professionals and increasing awareness of the problem by policy groups. The National Cancer Institute and the World Health Organization set out to document the degree of this problem, and they utilized the help of the Pain Research Group at the University of Wisconsin Medical School in Madison under the direction of Dr. Charles Cleland with grant support to develop a cancer pain self-report tool. And currently this research group is the Department of Symptom Research at MD Anderson. In terms of BPI development again, at the time in the 1970s, there were several pain measurement tools in existence. For example, the McGill Pain Questionnaire that we'll talk about after the BPI. But upon interviewing patients at the time, it was determined that existing tools were designed really to measure non-cancer pain, and they were maybe too long or complex for patients to complete. And some of the items in the existing assessment tool set did not pertain to cancer pain or were too ambiguous. Therefore, as a consequence, the pain research group set out to develop an instrument that would take a short time to complete, be easy for patients to understand, could be self-administered in literate patients, or could be completed by interview otherwise, and could be easily translated into other languages, and also could capture both pain severity and the perception of pain interference. This picture I wanted to show you is of a fish found in the waters of Hawaii. It's called a masked angelfish because it looks like the fish is wearing a black mask. But this is a fish that is abundant in the waters of Hawaii, but very rare in the aquarium trade. Because they are located primarily in areas where fishing or collecting ornamental fish is illegal. But on occasion, these fish are found in deep waters, maybe several hundred meters, in areas where it's legal to collect them. So not an endangered species, but very rare and very prized among ornamental fish collectors and fish and reef hobbyists. This is a female coloration, a white body with a black mask. So the pain research group used at that time current psychometric standards as a guide for construction of the scale. And these standards included test validity, content, criterion, and construct, as well as reliability, internal consistency, and test retest. The researchers found that there were 2 dimensions of the pain experience that seemed to account for most of the variability in the way that patients would describe their pain. Dr. Cleland referred to these 2 dimensions as a sensory dimension and a reactive dimension. The BPI was therefore constructed to include these items that reported the sensory dimension, pain intensity or severity, and the reactive dimension, pain interference with daily function. Of course, the severity and impact of function is included in the areas of assessment, as well as a location of pain using a pain body diagram, where the patients will mark on this diagram where they're experiencing pain, as well as a section on pain medication usage and the amount of pain relief from the pain medication usage, with a typical recall period of 24 hours, or you can change it to 1 week. The BPI does respond to both behavioral and pharmacologic interventions, and the method is, again, self-report or interview, and the time that is required to complete this assessment tool is 5 to 10 minutes, depending on whether or not it's a short form versus the long form of the BPI. And this is a picture of the male masked angelfish, a different coloration, kind of striking, beautiful orange colors and what are called streamers here on the tail. Very beautiful fish. Now, the BPI short form is more suitable in the clinic setting, and it retains from the original BPI the pain body diagrams, 4 pain severity items, 7 interference items, and a question about pain relief after treatments. And very briefly, I did want to show you this. I went last month to Hawaii and visited the Waikiki Aquarium, where this fish is found, and again, very unlikely for you to ever see this fish outside of the Waikiki Aquarium. There was a collector a few years ago who paid for a pair of these fish, paid $30,000 US, which is nung lan baht, for 2 fish. Sushi, yeah. But very expensive fish, and this is what this works. Well, the video must not be working, but very majestic animal. This is what the BPI does look like. This is what the form looks like with the pain severity and interference items, the pain body diagrams, and some questions about medication usage in response to treatment. And this is the BPI translated into Thai, and we use this in our intake forms. Now, there's also a McGill pain questionnaire that differs from the BPI. The MPQ is actually a multidimensional measure of pain quality rather than severity, intensity. And the short form consists of 15 descriptors that is represented from the original MPQ. 11 of the 15 descriptors are sensory descriptors of pain: throbbing, shooting, stabbing, sharp, cramping, gnawing, hot burning, aching, heavy, tender, and splitting. And 4 of the 15 descriptors are affective descriptors: tiring, exhausting, sickening, fearful, and punishing, cruel. Each one of these descriptors is rated using a 4-point verbal rating scale: none, mild, moderate, and severe. And this fish is called the Achilles tang, also found in the waters of Hawaii. Oh, and then there's a present pain intensity verbal rating scale and visual analog scale included in the form. And this is what the short form McGill pain questionnaire looks like. Again, you can see the 15 descriptors here that are each rated with a verbal rating scale, a visual analog scale here, a present pain intensity verbal rating scale. Then there is the MD Anderson symptom inventory, again also known as the MADASI. It was also developed by Dr. Charles Cleland, and it was based on the BPI. Now, this is not just a measure of pain, of course. Since multiple symptoms coexist in the cancer patient, a multi-symptom assessment tool was created. And the MADASI consists of 13 core symptom items rated with a numeric rating scale, as well as a symptom interference section. Part 1, the 13 core symptom items that are rated at its worst in the last 24 hours with an NRS are pain, fatigue, nausea, disturbed sleep, emotional distress, shortness of breath, lack of appetite, drowsiness, dry mouth, sadness, vomiting, memory difficulties, and numbness/tingling. And then part 2 is the 6 interference items rated on a numerical rating scale based on all of the symptoms, not just pain. This is general activity, mood, work, relations, walking, and enjoyment of life. And this is a picture of a Japanese pygmy angelfish found off the waters of Japan. Very striking colors, and again, a very highly prized specimen in the aquarium trade. And this one is not nung lan baht. This is more like $3,000 US. Much cheaper. The MD Anderson symptom inventory, this is what the form looks like. And there is a Thai translated version as well. And then we move on to the Edmonton Symptom Assessment System, otherwise known as the ESAS. The ESAS is a tool that was originally developed in 1991 by the Edmonton Regional Palliative Care Program in Alberta, Canada, that assesses 10 symptoms commonly present in the advanced cancer patient. And again, it's a pain, nausea, tiredness, depression, anxiety, drowsiness, appetite, well-being, shortness of breath, and then a patient-specific symptom that the patient will actually fill in themselves. This is a school of powder blue tangs found in the Indian Ocean. One of my favorite fish. Each of these symptoms is rated by a numerical rating scale. A pain body diagram is included. The revised version, called the ESAS-R, provides a brief definition of possibly confusing terms, rearranges the order of items so that they make more sense, and specifies a time frame of now. Also provides an example for the other symptom field for the patient to complete. And this is what the ESAS-R looks like. Now we move on from the pain and symptom assessment tools to one of the risk stratification tools for opioid prescribing, which is called the Screener and Opioid Assessment for Patients with Pain. And this is something that we include in our forms for the patients to fill out, especially with initial consultation. And because we have to assess patient risk of aberrant use and drug diversion, this is an opioid risk assessment tool that helps determine the degree of monitoring necessary for patients on long-term opioid therapy. And a score of 4 or more suggests a higher risk for drug abuse, and therefore, with a positive screen, the patient needs close monitoring. These are pictures of a juvenile on top and a male, adult orange shoulder tang. And this is what the SOAP screen looks like. These are the questions that are rated with a verbal rating scale. Number 1, how often do you have mood swings? Never, seldom, sometimes, often, or very often. How often do you smoke a cigarette within an hour after you wake up? How often have you taken medication other than the way it was prescribed? How often have you used illegal drugs, for example, marijuana, cocaine, etc., in the past 5 years? And how often in your lifetime have you had legal problems or been arrested? In this example, the patient scored a total score of 3, but if the score was 4 or higher, that would be a positive screen. We move on to the final 2 assessment tools, and these are actually not ones that we collect, but we see these in the oncologist's notes all the time. And again, the first one is a Karnofsky performance status, and it's a standard way of measuring cancer patients' ability to perform daily tasks with a score ranging from 0 to 100, and the higher scores mean that patients are better able to carry out ordinary tasks. And I mentioned before, this KPS is used by oncologists to determine prognosis and to measure changes in functional capacity, or to decide if a patient could be included in a clinical trial. And this is a fish called the gem tang, found off of the waters of Africa in Mauritius and Madagascar. And like a gem, it is expensive, $1,000 to $2,000 US. This is what the KPS looks like. Again, 100 is normal and 0 is dead. And so that's what the KPS looks like there. And then we have the ECOG, the Eastern Cooperative Oncology Group performance status, very similar. Grade from 0 to 5, with 0 being fully active, able to carry on all pre-disease performance without restriction, and 5 is dead. Now that was part 1 of the lecture about pain symptom assessment tools, quality of life measures. But part 2, I was asked to talk very briefly about a couple of new drugs that are either newly available in Thailand or will be available in Thailand soon. And the 2 drugs are Targin, and Butrans, and I have no disclosures, no conflict of interest, nothing to disclose. The first medication, called Targin, is basically a prolonged release oxycodone/naloxone combination in a again, a prolonged release 2-to-1 ratio. And the strengths available, according to the full prescribing information online, are 5/2.5 up to 40/20 dosage forms. And according to the manufacturer of this drug, the clinical indications are for severe pain that can only be managed with opioid analgesics. The second line symptomatic treatment of patients with severe idiopathic restless leg syndrome after failure with dopaminergic therapy. And of course, the component in Targin, naloxone, is an opioid antagonist, and it is added for the indication of counteracting opioid-induced constipation by blocking peripheral opioid receptors in the gut, therefore maintaining the central opioid agonist effects from the oxycodone. According to the manufacturer, the usual starting dose for opioid-naive patients is 10/5 twice a day or every 12 hours, with a maximum recommended daily dose of 160/80. Can be taken with or without food, but must be swallowed whole. And there is a caution in the package insert that there's no clinical experience in patients with cancer associated to the peritoneal carcinomatosis or with subocclusive syndrome in advanced stages of digestive and pelvic cancers. Therefore, the use of these tablets in this population is not recommended. Of course, these tablets are not recommended for preoperative use or acute postoperative pain, these being prolonged release medications. Any abuse of the tablets, for example, by drug addicts, is strongly discouraged. This is taken from the package insert. If abused parenterally, intranasally, or orally by individuals dependent on opioid agonists, such as heroin, morphine, or methadone, these tablets are expected to produce marked withdrawal symptoms because of the naloxone component. These tablets, of course, consist of a dual polymer matrix intended only for oral use. Therefore, abusive parenteral injections of the prolonged release tablet constituents, especially talc, can be expected to result in local tissue necrosis and pulmonary granulomas, or may lead to other serious, potentially fatal, undesirable effects. According, again, to the manufacturer's package insert, there is a study that seems to support this medication's utility in improving opioid-induced constipation compared to the opioid analgesic as monotherapy without the naloxone. I provided in the lecture slides a definition of OIC according to the Rome 4 criteria, as well as a table of commonly prescribed medications over the counter used for opioid-induced constipation. Some of the first-line agents that we use at MD Anderson include Docusate, as well as Senna, but we also recommend polyethylene glycol and sometimes lactulose, magnesium citrate, and some other over-the-counter medications for OIC. Now, there are also prescription medications for OIC in non-cancer pain, and the ones that we have experience with include methylnaltrexone as well as naloxegol, and these are peripheral antagonists of the mu-opioid receptor. And the methylnaltrexone is available in both an oral form as well as a subcutaneous dosage form. And just a quick PubMed search on prolonged release oxycodone naloxone combination does yield a number of studies that are randomized controlled trials that do support the effectiveness of this medication compared to monotherapy for analgesia and opioid-induced constipation. This is a picture, again, I mentioned that I visited Hawaii last month, and on the left is a view of Waikiki Beach in Honolulu and the island of Oahu, and a beautiful rainbow here. And I did take a picture of a sea turtle while snorkeling in Hanama Bay. And I know it's not too far from Thailand, so I hope you can visit Hawaii someday if you haven't. It's a beautiful place to visit. A lot of Japanese tourists there too, and good Japanese food. So the second medication that I was asked to discuss is something called Butrans, which is a buprenorphine patch, a 7-day transdermal delivery system. And again, according to the drug manufacturer, the indication is for management of pain that requires daily around-the-clock long-term opioid treatment, and for which alternative treatment options are inadequate. Appropriate patients, according to the drug maker, are patients who are taking non-opioid therapy and whose chronic pain is no longer well controlled, or are taking lower doses of an immediate release opioid therapy and whose chronic pain is no longer well controlled, or are not tolerating their current medications. This is an illustration of the transdermal delivery system, a cross-section diagram of the patch. The buprenorphine is bound in an adhesive matrix and released gradually. When the Butrans patch is applied, buprenorphine diffuses into the skin and enters the systemic circulation. Steady-state plasma buprenorphine concentration levels were achieved by day 3 during the first application, and Butrans therefore may be titrated after a minimum of 72 hours based on the pharmacokinetic profile and time to reach steady-state levels. In terms of dosing, the manufacturer recommends for opioid-naive patients to start at 5 micrograms per hour, change the patch every 7 days. For patients who are opioid experienced, as defined, as you'll see here, if the morphine equivalent daily dose is less than 30, again, start at 5 micrograms per hour when doing the opioid rotation. If the daily dose is between 30 and 80, start at 10 micrograms per hour, changing the patch every 7 days. But if the morphine equivalent daily dose is greater than 80, Butrans may not provide adequate analgesia, being a partial agonist. So consider the use of an alternative analgesic, according to the drug manufacturer. I'm sorry? Oh, we'll get to that. It's in the next slide. It's one of the next slides. In terms of the patch application, rotation, and disposal, apply Butrans to these 4 sites bilaterally. So there's a total of 8 different sites to rotate the patch to. And the patient has to wait a minimum of 21 days before applying to the same area. Now, these are the special considerations for the buprenorphine patch. Importantly, it is a medication that can prolong the QT interval. So it was recommended not to exceed 20 micrograms per hour. Certainly in the manufacturer study, at 40 micrograms per hour, they did definitely see QT interval prolongation. Do not abruptly discontinue Butrans, rather taper every 7 days. Be aware of the risks of respiratory depression. You might have to check liver enzymes initially because of the chance of hepatotoxicity, hypotension, a risk of seizure in those with seizure disorder, a risk of opioid use disorder, skin site reactions, etc. Patients on a high morphine equivalent daily dose may not be appropriate candidates for Butrans. And again, the manufacturer suggests that if the dosage is, patient is on 80 milligrams per day of morphine or its equivalent, then this, being a partial opioid agonist, might not be the best choice. And this is an aerial view of MD Anderson, where I work, and my colleagues here. And it's again, a great place to work, the largest medical center in the world, and I hope you will be able to visit one day. But thank you.
Chai. This brings us to the Q&A question. Q&A sessions. Does anyone has any question? Please raise your hand.
So Butyran is coming into market here. One thing I wanted to make us, I want to make a little bit of additional comments on this, because Butyran is not a pure mu agonist. It is mu agonist and kappa antagonist. So it's a partial agonist. Okay? But although it's a partial agonist, it adheres to the mu receptor very, very avidly. It's very difficult to take it off. Okay? So what it will do is it will displace other opioids. Okay? If the patient is on morphine, you give them this, they're going to have a little bit of withdrawal because this thing is, it will stick to the mu receptor very avidly. Okay? But it's only partial agonist. So they don't get the full mu agonistic effect. So there's a possibility of withdrawal. And also, as an anesthesiologist, patient is taking on Butyran patch coming into surgery. Okay? Now, what do? You're going to use a fentanyl IV for surgery. What's going to happen? Fentanyl is not going to work very well because Butyran is already occupying the mu receptor. Therefore, fentanyl becomes less effective. And so they're going to feel a lot of incisional pain during surgery. So it is mandatory that you taper them off 3 days before surgery. Okay? So those are some of the things that you should be aware of when using Butyran patch.
I don't have extensive experience with this medication, but I have used it in several patients, and I have found the same situation Dr. have described. You might be familiar, but the other provider might not be. So one of my patients, for example, is a patient with a lot of nociceptive and neuropathic pain. His neuropathic pain actually happened after a heroin overdose. So this is a patient with a lot of pain and probably with good indication. He also has cancer, so he had good indications for the use of narcotics. However, he was in a big trouble for using heroin. So I found this medication to be a good alternative for this patient, and he has done very well on it. So his pain is well controlled, and I don't have the concern of the use of narcotics. However, in one of the occasions, he was hospitalized, and probably other providers were not aware, and they were putting a PCA and other type of narcotic for pain control. Unfortunately, I find out too late that he was already there. I don't know how did he do with those medications when he was still on the patch.
Usually I use this Suboxone or Butyran or for someone who have a chronic pain / addiction, but like someone in the border between chronic pain and addiction. The problem is there's a ceiling effect of these medications also, which I'm not sure that is that going to be a problem for cancer pain patient because sometimes the pain is so intractable. Yeah, and like Dr. He already mentioned that if the patient comes for surgery, you should stop it for 3 to 5 days. Otherwise, no matter what you give, patient gonna appreciate it because it's already occupied by the Butyran.
Does anyone else has any question?
Good afternoon, ladies and gentlemen. I'm Dr. Sun Hak from Cambodia, 4th-year resident in emergency department. I honestly have not much experience with the new drugs and to control the pain in cancer. Honestly, we doesn't really know most of those medicines. I have a concern for the assessment in pain for cancer patients. Usually, most of the doctor, healthcare providers in my country are usually lack in knowledge about pain, especially in cancer patients. Most of them are opioid phobia doctor. They mostly use morphine most of the time. It's when patient, oh, it's really painful, morphine, really painful, morphine. Those are opioid doctor, opiophobia, sorry. Usually, my experience for pain control in cancer patient, usually I divide them by two. A, a patient with an oncologic emergency, such as bone fracture, metastasis, epidural metastasis. Those type of patients usually has really bad pain, intensive pain. And other patient without them usually much better. Also, the assessment system that Dr. Thomas had shown us are really valuable information. But a study from EPIC, a European perspective into cancer and nutrition, showed that only 27% of the doctor ask the patient about the pain, using like a sophisticated system to identify how bad the pain is. Usually, in my experience, I usually use the step up and step down analgesic ladder by WHO. We usually giving high multi-modality and like intensive pain control, IV pump, epidurals, and a lot of stuff to help the patient through the acute and intensive pain, and then step down quickly after the pain is controlled. Would you mind share us the methods or the use, like what do you daily use to assess the pain of the patient? Thank you.
When we see patients as an initial consultation or for follow-ups, we do have them complete an intake form before we see them for the clinic visit. And in this intake form, it does include the assessment tools that you do see or that I presented earlier, including the BPI, some version of the ESAS, we do also have questions about medication usage, response to treatment, and so we try to get as much information as possible in the limited amount of time that we have for each clinic visit, which is at MD Anderson we allot 20 minutes for a visit for a follow-up. We give a little bit extra time for initial consultations, so we gather a lot of information from these assessment tools, and that help us to base our decision making. And we are fortunate that we do have a variety of different analgesics and adjuvants and opioids compared to a lot of other countries. So there's a lot more flexibility to prescribe opioids with different potencies, different pharmacologic properties. And yes, we do utilize the World Health Organization's analgesic ladder, and we offer interventions as you do with nerve blocks, peripheral joint injections, epidurals, intrathecal therapies, other types of neuromodulation. We have Dr. Rodan's going to talk about all the interventions that we offer. But yes, we have vertebral augmentation, spinal cord stimulators, dorsal root ganglion stimulation, and a number of other modalities that Dr. Rodan will discuss in detail later today. So yeah, I think it's you do the best you can with the resources that you have available, and it sounds very reasonable. Your practice, you know.
Yes, we have extensive questionnaires for the new patients. We have solved so we can assess their opioid risk factors, and they have a long form of all these questionnaires. So they spend extensive time as a new patient filling out these forms. But as a follow-up patients, we use simpler forms, so we can assess. We can look at the outcomes. Okay, whatever we do for them are we making any differences for them? So that's why these questionnaires are very important outcome studies. Okay, so and then based on that, we can actually see what we can change our. If patients still continue to complain of neuropathic pain, then we can modify our treatment plans. So these questionnaires are a powerful tool, not only managing patients' pain, but also looking at the outcome studies. So that's why every patient has to fill it out. Yes, it does take time, but our nurses enter these numbers into the computer, so we have a lot of database.
So you say you're emergency medicine, right? Yeah, so basically I can talk to you from my perspective. So the lack of education in pain management is epidemic. It's pretty much everywhere. United States is not the exclusion. It's all over the place. So as an emergency physician, I can tell you that 85% of the population comes to the emergency department for pain of any source. 40% of those people, they have chronic pain that we're not trained to identify. We don't know how to identify neuropathic pain or many pain syndromes that we get in the emergency department. Realistically, I would say it's almost impossible to do a good assessment of our patients. A OP visit, in theory, is 45 minutes where you can make a good assessment of the patient, make a plan, a screening test, and then the follow-up therapy. That's what has been described in the literature, 45 minutes. I don't think even in our pain department we can do that, let alone in the emergency department. It's a chaotic place, and basically that's not going to happen. There are some tools that have been developed probably to be able to use in the emergency department, hopefully more brief and more efficient, but at this time, there is a lot of gaps for the patient with pain visiting the emergency department. There's a lot of deficiencies that we had to cover. And by the way, that was probably the main reason I switched in my career. I did more than 10 years in emergency medicine, and I realized that I was able to offer more to my patients in the quality of life than just what I did in the emergency department. Because a lot of our chronic pain patients end up in the emergency department. They don't have anywhere else to go. They have pain. They go from physician to physician. They don't know, many physicians don't know how to diagnose many things, so they end up in the emergency department.
Just to add up what Dr. Carlos mentioned, that what we do in Sierra is when we try to measure quality of life and use the form, it's wasting a lot of time. So what we do now is while patient waiting, our nurse team will ask the patient the form, and we try to use the less complicated one, which is BPI. It's already validated in Thai for how many years ago. So, and while they are waiting, they can have a conversation with the nurse, and Thai patient, they love it. And they can just have a small talk, social talk with the nurse, and then when come to the doctors. And of course, we're doing the full form when we trying to gain the information for the research reason. So, but for practical, you can you can adapt it from the BPI or any other form, or any even palliative care score or ESAS we have is already all validated in Thai already.
I would like to share our practice in Silat Hospital. As Dr. Prani said that we use the BPI and ESAT all of the cancer pain patient from the beginning and every follow-up. Moreover, we use the because of performance data, there are so many tools like PPS, palliative performance data, Karnofsky, and ECOG, which very it depends on the main specialist. Like radiologists prefer to use Karnofsky, oncologists prefer to use ECOG and palliative prefer to use PPS. So I try to let everyone in my clinic to know about 3 of this performance data and try to correlate each other, and then I think it's very useful if others hospital or others like Laos or Cambodian can use like the tool like Silat Hospital, because the population in our area is the same. Okay, if there is no more question, please thanking to Dr. Thomas Chai for very useful, insightful like this lecture.
So thank you, Dr. Thomas Chai. And because we finished a little bit early, which is good for us because I think a lot of people in this room are anesthesiologists. We are familiar with having lunch at 11 o'clock, so it is quite good for us. So we're gonna start the session of Luncheon Symposium now, okay? The Luncheon same as yesterday, the Luncheon Symposium will be served in this room. And again, you can choose one of this menu and please write down the number that you want into your coupon and hand it into our staff. And the lunch will be served in a few minutes, okay? About the moderator of the Luncheon Symposium, I think there is no need to introduce him anymore because everyone knows him already. Ladies and gentlemen, again, please give a big round of applause to Dr. Nantasorn Sinbunyakul.
Thank you. I hope that the morning break already get digested because now you have to create a room for the lunch. And we have 6 meals today. When we are preparing for the next presentation for the lunch symposium, just would like to tell the menu in Thai. For the first one, it is in Thai, ข้าวสวยผัดหน่อไม้แกงใต้ไก่แล้วก็ไก่ก้อนทอดนะครับอันดับที่2เนี่ยเป็นข้าวสวยนะครับคั่วกลิ้งไก่นะฮะนะแล้วก็ชุดผักไก่ปั้นทอดนะครับอันดับที่3เนี่ยเป็นข้าวสวยนะครับข้าวผัดโหระพาหอมนะครับหมูทอดไข่ดาวอันดับ4นะครับนะเป็นข้าวผัดต้มยำตะไคร้ไก่นะครับนะใส่ไส้กรอกไก่ทอดไข่ต้มอันดับ5เป็น vegetarian ครับข้าวสวยผัดเห็ดออเรนจิไข่แขนงผัดพริกสดแล้วก็อันดับ6เป็นฮาลาลนะครับเป็นข้าวสวยปลา3รสไก่ทอดไข่ดาวบัตเตอร์ชีสเค้กครับแต่ว่าฮาลาลกับ vegetarian นี่มีอย่างละ5ชุดนะครับแล้วก็ขอ preserve ให้คนที่จำเป็นจริงๆนะครับแต่ก็ดูน่ากินนะฮะฮาลาลก็เราจะมีร้านซิมทั้งหมดของ2เลคเชอร์นะครับนะเลคเชอร์แรกเนี่ยก็เป็นเรื่องของ breakthrough pain breakthrough cancer pain นะครับแล้วก็ fentanyl rapid action นะครับนะโดย Carlos Rodan นะครับนะสปอนเซอร์โดย Minarini นะครับนะแล้วก็อันที่2นะครับอันแรกนี่จะเป็นภาษาอังกฤษนะครับนะส่วนอันที่2เนี่ยเป็นภาษาไทยนะครับนะเป็น cancer pain management with the other opioids นะครับ in WHO analgesic ladder step 3 นะครับนะอันนี้เป็นไทยนะครับโดยอาจารย์ศิษย์การของเรานะครับนะก็เดี๋ยวขอเริ่มเซสชันแรกเลยละกันนะครับนะก็ขออนุญาตแนะนำตัวสปีกเกอร์ของเรานะครับนะตัวดร. Carlos Rodan นะครับนะดร. Carlos Rodan เป็น Assistant Professor นะครับนะจาก Department of Pain Medicine นะครับที่ Division of Anesthesiology นะครับนะที่ MD Anderson นะครับ Texas Houston นะครับนะรวมถึงตัวดร. Rodan นี่มี dual position นะครับเป็น Clinical Professor ด้วยนะครับนะที่ Emergency Medicine Department นะครับชื่อ UT Texas นะครับนะ Ladies and gentlemen, just want to introduce Dr. Carlos Rodan. He is an assistant professor at the Department of Pain Medicine at the Division of Anesthesiology and Critical Care at the University of Texas MD Anderson Cancer Center. And he also take a joint appointment as a clinical professor at the Department of Emergency Medicine at the University of Texas Medical Center, Medical School at Houston, Texas also. He will lecture us in this lunch symposium for the topic of breakthrough cancer pain and fentanyl rule by Dr. Carlos Rodan. Ladies and gentlemen, please welcome Dr. Carlos Rodan.
Thank you. Thank you very much for this invitation. I'm hoping it's not the last one. I'm planning to come back next month. I'm enjoying very much spending time here and visiting Bangkok. So in cancer pain, there are many challenges, as we all know. Among those challenges, definitions and agreeing into terminology is one of those. This is a perfect example. Breakthrough cancer pain, just the definition alone, has been a challenge for many. So I'm going to touch base on a few subjects of this topic. The definition has been very difficult to come across with because many experts cannot agree into the terminology, but for some, overall, it's been stated that breakthrough cancer pain is pretty much a transient exacerbation of pain. It could be spontaneous, or in other way, it could be predictable or unpredictable. So by saying a transient exacerbation of pain, it can mean many things. It can relate to many other things that we can think about. It has been defined as an incidental. I'll probably call it, instead of incidental, I'll call it dynamic. It's a pain that can be precipitated. It can be also predicted. And idiopathic, one perfect example of predictable or incidental pain, it comes to me, for example, a patient with colorectal cancer who has extremely painful bowel movements. So when the patient needs to go to the bathroom, he or she knows that the pain spikes pretty high. So that can be one perfect example. The patient with metastatic lesions to the spine who's receiving radiation therapy. Many of those patients, they have difficult time staying in the same position while they receive the therapy, or even patients to undergo an MRI. They have a lot of pain. That could be also the definition of breakthrough pain. About idiopathic pain, it's a pain that we cannot predict. It's unpredictable and we don't know the cause, but that can easily fit under the description of neuropathic pain. So the characteristics of the breakthrough pain are pretty much the rapid onset, short duration, and severe intensity. 2016, another initiative to try to define and consolidate the definition of the breakthrough pain, the Delphi survey. The Delphi survey, they consulted 52 authors and experts on the field, and they tried to address 20 different issues with these experts. Only half of them answered the survey, and then the second half answered a late survey after a second request. The one interesting thing that they could only agree on 13 out of 20 different issues. So that can tell you the challenges of the definition of breakthrough pain. In this slide, you can see some of the information has put together. So it basically confirms that challenge that we have in front of us. If you look at severity, the range of the severity of the breakthrough pain goes from mild to excruciating. I don't know, pretty much all the pain fits in there. How about the duration? We're talking about 1 second to 24 hours. That doesn't help us too much to make this, to define this type of pain. And the prediction or unprediction, it depends on the etiology of the pain. So the causes of breakthrough pain or this pain, these pain's exacerbations could be numerous. It could be the cancer itself. it could be the therapy, it could be other issues. So at the end of the day, we don't really know what is causing these exacerbations of the cancer. What is well known is that in cancer pain, most common type of pain is mixed, not necessarily isolatedly nociceptive or neuropathic, but mostly it's a mixed type of symptomatology. The epidemiology could be very wide also. The more advanced the cancer is, the higher the chance that the patient is going to have episodic exacerbations of the pain intensity. What we all know is that the pain, those exacerbations of severity of pain, they can be a big burden to the quality of life of our patients. It can interfere with every single sphere of the patient's quality of life. And when the pain becomes the center of gravity of the patient, all the spheres can be affected. Patient with pain cannot sleep. Patient cannot sleep, it's going to be lack of energy. Then the activity level is going to be down. The mood is going to go affected. So pretty much with all the spheres, if the pain is a starting point of all of this symptomatology, we can definitely have patients that are failing therapy and more specifically the pain management. The diagnosis of breakthrough pain, it can be based on your clinical skills, because if the definition is very wide and the definition is not very clear, obviously the diagnosis is going to be also very subjective. Most important, when you talk to your patients, you can break down the quality of the pain. That's what I do with my patients. For you anesthesiologists, for me as an emergency physician, you remember that an electrocardiogram, every single portion of the lead, every single portion has a different meaning. Same thing with the pain. With pain, you need to break it down, and then you can address every single aspect of the pain. Go by the nature and location, frequency, duration, pain episodes, relationship, makes it better, what makes it worse. Just breaking down the quality of the pain, you're going to be able to have better information and most likely more accurate diagnosis and a better way to treat your patients. That applies also to breakthrough pain. So to this point, what strategies do we have to treat this patient with the pain exacerbations of breakthrough cancer pain? So in general, the most common strategy that we use is the use of short-acting opiates. A patient that is hospitalized, that's pretty much what we do. How do we start? Treating the background pain, the overall presence of pain, most likely will decrease the number of episodes of breakthrough pain throughout the day. So what probably a good way to start, for the non-pain trained provider, would be the WHO ladder, where it states pretty much the levels of the pain care that you're going to be on an escalation. Unfortunately, this type of resources don't provide any recommendations about the breakthrough pain. So we're still in zero. What are we going to do with those patients? So if you control the background pain or the underlying pain, or you anticipate the pain, you're probably not be in a better shape to manage these patients. When you really address this patient with cancer, you understand that there are many challenges, and in many of those, probably the end result is to use another narcotics. Patients have many limitations. Cancer patients have a lot of complexity, and their profile can be a lot more complex. So in many of the cases, we're going to end up using another narcotic, even if that's not what you were intended to do. So the National Comprehensive Cancer Network in 2013 made two statements that probably prevail. Supplemental doses of analgesics are needed to manage these patients' exacerbations of pain. Pretty much we're talking about the same terminology, breakthrough pain or pain exacerbations. Even if the patient has not any baseline treatment for underground pain, so those exacerbations might actually need an extra or initial dose of narcotic. But what are those characteristics that we're looking for? Those, as per the definition, those exacerbations of pain are very intense, are very short-acting, and So we need a medication that is a rapid onset, short duration, and high efficacy. So what do we have right now? If we have a patient with uncontrolled pain, in this graph is showing us pretty much the spikes of the pain. Even the patient is, if the patient doesn't have any treatment for underground pain, or even if the patient is taking some long-acting narcotics, those exacerbations of pain might actually happen, and they are describing the red shadows. For the medications that we currently use, the short-acting narcotics, we have a problem because those medications are not matching our needs. If the pain exacerbation is rapid and short-lasting, and we use the short-acting narcotics, usually they take longer time to be effective. So we already having the patient with a long period of time with no coverage for the pain intensity. And then they can be good enough, but too late. Similarly, they can be of long-acting duration. So the patient, after taking these short-acting narcotics, they might be exposed to more side effects, and the effects of the narcotics will be actually still in effect when the patient already doesn't have pain. So it's a mismatch. Ideally, these medications to be used for the breakthrough pain go with the definition, and they should be ideally rapid onset. They should be able to work quickly as the pain onset appears, or when you can predict the pain, you can take the medication before the pain starts. The second thing, the medication should be short lasting. So as I mentioned, the side effects and the prolonged effects of the narcotics are not an issue for the patient. So short-acting narcotics that we currently use includes morphine, oxycodone, hydromorphone, methadone, fentanyl. I already heard they're not available everywhere, but those are the most commonly. Even methadone is considered short-acting. Unfortunately, it's a medication that is it's a quick onset, but very long-lasting. So you're not gonna use methadone for a breakthrough cancer pain, but it's listed as a rapid onset. So morphine is considered the landmark of all the opiates. So everything that we do in pain to study narcotics, we compare to morphine. That's why we use the morphine daily equivalent dose, because that's the landmark, that's the way to compare. On some of the studies that they mentioned here, they use a morphine to compare to. So if you use intravenous morphine, that probably could be a medication that might work for your breakthrough pain, but there is a big limitation. One, that is intravenous. So this is not going to apply for the patient that is outpatient, that the patient that is not hospitalized. The onset of action is presumed to be around 30 minutes, so it doesn't match quite there the need for the patient. This is a slide that shows the pros and cons of current narcotics. We're talking again about mostly short-acting narcotics, but other has been considered. Non-opiate analgesics, we're talking for the most part of the anti-inflammatories. Some advantages, but more disadvantages. There's a dose limiting or toxicity. There are some concerns about cardiovascular profile because they are COX-1 inhibitors. So some papers have been published about the poor profile in the patient with cardiovascular risk. And there's no really good evidence of the efficacy in the breakthrough pain. The short-acting opioids I already mentioned, they can be long-lasting, so they can have an additional side effect for the patient. They have been studied, they have shown efficacy, and they're convenient. But again, one problem that we have is that we're referring to the short-acting use intravenously, not from the PO. And they might have, some of them, they might have lower onset of action than is required. Some other adjuvant therapies have been used, but they haven't been recommended. So with the current alternatives, I mentioned already, intravenous probably would be the ideal way to manage this type of pain. However, not every patient that you have with breakthrough pain is going to be in the hospital with an IV access. So you have to consider other alternatives. The other routes, like rectal, oral, parenteral, transdermal, they don't seem to match our needs. So the new trend of what is being now used in many places is transmucosal administration. And that's probably the one thing that I was going to mention. So what is good about using this route when using transmucosal? Number one, taking advantage of the anatomy of the oral mucosa. There's a high vascularity. With a high vascularity, there's a possibility of rapid absorption, because there's a lot of vessels in the oral mucosa, so that you take advantage of that, make it simple, simple to use. The second thing, they're lipophilic. We're talking now more specifically about other medications like the fentanyl. They can be lipophilic, and therefore the rapid absorption through the mucosa and the first pass metabolism absence. So when these medications don't have to go to the liver and be metabolized, they can be released directly into the bloodstream and be more effective. So this is probably something that the industry is looking at, taking advantage of the anatomy of the mouth, using the lipophilic solutions, and also being able to bypass the liver metabolism. So for this, there are different medications that have been released, and some of them have been studied. Many of those, I think all of those are already available in the United States. I have experience with some of them, but not with all of them. So we have the fentanyl sublingual tablets, also the transmucosal, which is comes in lollipops, intranasal, and pretty much two intranasal products. They all have the same profile of using the lipophilic and taking advantage the high vascularity of the oral mucosa. One thing that I put here is not part of what I was giving for these slides, is that you have to be careful with when you are moving from one medication to the other one. They're not interchangeable, so they're no one-to-one. If the patient is using lollipops or sometime, doesn't mean that the same dose is applied to the nasal spray. So you have to be very careful when you are titrating or when you're switching from one product to another one. Here's a comparison. There's a table comparing a little bit of the profile of those medications that I mentioned. We're talking about all the fentanyls, transmucosal in different presentations. The availability is pretty similar. The Tmax is the time that requires to reach a maximum concentration. And some of them, for example, the nasal spray seems to be faster, but similar. Probably still the profile looks better than using the regular morphine. The Cmax is not climax. Is the maximum concentration reach into the bloodstream. If you see some of them are better than the other ones, the question is which one is available and which one are you going to be able to use in your patient. I'm going to refer a little bit to each of them in other slides. In the lower part, you see the half-life of all of them. They're pretty similar, in my opinion, except for this one. They can be pretty long. So in this case, for example, they compare the fentanyl sublingual tablets versus morphine. I put in red just the highlights. The slides that were provided, they were much busy, so I just put probably the most concise information to give you a better idea. So in this case, they tried to evaluate the efficacy and tolerability of the sublingual fentanyl versus the morphine sulfate, the short-acting morphine. So it was a prospective double-blind control study. That's a good part, so that's a plus for the study. The patients were allocated one-to-one to morphine versus the fentanyl sublingual. That's also good. One thing that they looked at was the onset relief, pain relief in minutes. So if we go back to the pharmacological profile of the medications, we all know that anything that you use transmucosal fentanyl-wise is going to be the morphine. You know, they have rapid absorption, vascularity, and lipophilic, so there's really no comparison. But every single study that they mentioned, they actually applied that concept probably to demonstrate that it's a much faster medication. So the pain intensity was measured at long terms, not just at the time of the use, and they measured at 3 days, 7 days, 15, and even 30 days. The sublingual fentanyl was significantly faster on relief than the oral morphine. And the satisfaction scores were much higher, obviously, on these patients. Another one would be a comparison between the transmucosal fentanyl citrate. We're talking about the lollipops. Probably this is the ones that I see more commonly used in the United States. In this case, they were trying to compare also. One thing is that a lot of the patients that they included in this study were ambulatory patients, so not necessarily the sickest population. a double blind, double dummy. Double dummy means that the patients can actually use the active principle or the placebo. In this case, they were allowed to use the fentanyl or the morphine. They were randomized and multiple crossover studies, so that goes up to the quality of the study. A few things that I observed that were not probably in the best interest were that the doses were very wide, from 200 to 1600 milligrams, so that micrograms should read. So that actually goes against the quality of the study because the range of the doses were pretty high, pretty wide. They also entered some terminology that, we're talking in pain, we're talking about a lot of ambiguity, and this one makes it even more ambiguous. What is acceptable side effect? Acceptable side effect for you is different from acceptable side effect for me. So that also goes against the study. But the primary efficacy was measured at 15 minutes as compared to compare the onset of the medication. And obviously we know the answer that at 15 minutes, the fentanyl lollipops are gonna be probably more efficient than the morphine. So they were significantly better to control the pain intensity than the morphine. The patients, at the end of the study, they had the option, because it was a crossover study, they were given the option to stay with the same medication to cross to the morphine. 94% of the patients, they wanted to keep using the fentanyl lollipops versus a very small amount, the 6% of the patients in the morphine. A few limitations of this product, the fentanyl lollipop, and I've seen it in my patients, what I've used. So the application might require some dexterity. The patient has to hold the lollipop in the hand and start rubbing it in the mucosa. If the patient applies in the tongue or in the gums, it's not going to be absorbed. If the patient is drinking a certain type of liquids, it can change the pH of the saliva, and therefore it might actually impair the absorption of the use of the medication. It's also I mentioned the dexterity. Patient with cognitive impairment of dexterity issues, they won't be able to use the medication. It's also reported to have bad taste for some patients, but I think more important than that, oral mucositis. I am a person that I like to see my patient with oral mucositis, and this is a big problem. The patient has oral sores. They won't be able to apply these lollipops in the mouth because it's pretty painful. You're going to be rubbing against the same areas of pain. And one thing that was not described also in these slides was the dental decay. They are known to cause dental decay. Patients develop cavities after using it for some time. So the next one was comparing the fentanyl buccal tablets. Those tablets were compared to oxycodone. In this case, was not to morphine. The objective of the study was to evaluate the analgesic efficacy and patient satisfaction compared to the buccal tablets. This was used more in chronic pain with no cancer. So unfortunately, the cancer population was not the main target of this study, and that was a problem. They also measured the 15 minutes onset of the effect of the medication. Good things about the study, that was randomized, double blind, and it was a multi-center. It was done in 42 centers in the United States. So the results, same thing. 15 minutes seems to be a good time to measure the efficacy of those medications, regardless of which one you're doing, the nasal spray, sublingual, lollipops. 15 minutes of onset was better with this medication than with the regular morphine. The pain relief was better also. Per patient satisfaction, the pain relief was significantly better in the patients with the fentanyl versus the oxycodone patients. And at the time of crossing over, the patients also preferred to use the fentanyl buccal tablets versus the oxycodone. This is the last one that I wanted to mention. This is a multi-center study where they trying to compare the fentanyl nasal spray versus the morphine. That was to evaluate the efficacy and tolerability of this fentanyl version versus the morphine. So it was a double-blind, double-dummy, multiple crossover study. So that goes good for the methodology of the study. In this case, they randomized patients to 10 breakthrough pains. 5 of them, I think that was from the design perspective, that was a very good study. They assigned 10 breakthrough episodes. 5 of them, the patients were given the fentanyl spray plus placebo tablets of morphine, and the other group were given the opposite. They were given fentanyl. They were given real morphine plus fentanyl, with placebo spray. So they were getting normal saline sprays. So after that, the endpoint was pain intensity, and of course, 15 minutes measurement of the pain. What they didn't define very well was how meaningful pain relief was. There was no a clear definition of the meaningful, what was described as a meaningful. The result, the fentanyl nasal spray was better than also the other medication. The pain scores were significantly better for all of them. It was a rapid onset, but it has some downsides. The nasal spray has a few issues. They report a lot more side effects than the other medications. They were also less likely to be used by the patients. About 6% of the patients, they reported a lot of local symptoms: itching, sneezing, coughing, stuffy nose, even sore, some nosebleeds after using the medications. So this medication was not the favorite from the patients. The last one I want to mention is a survey where patients were given 3 different fentanyl products, and they were evaluated they were given just the choice to use all of them. The patients were supposed to give the likable scale just to see which medication they prefer. So what happened was, from the results for the fentanyl lollipops, they were, for accessibility, they were rated the best. I'm not too sure if it was because this medication is more available, it's easier to find, you can find it. I understand here in Thailand probably it's not available, but at least in the United States you can have it almost in any pharmacy in the hospitals. So that was really the best for that. Nasal spray was really the worst, probably based on the side effects that I described, that the itching and nosebleeds, and definitely the sublingual tablets were really the best. Several reasons: it was easy to administer. It was apparently the flavor was more acceptable for the patients, and overall the impressions, the patients, they preferred that sublingual tablet, that the sublingual tablets were the best options. So just to finish, so the clinical diagnosis of breakthrough pain is still a challenge. As I mentioned before, 2016, the last initiative to try to put together the definition, in my opinion, still failed. Only 13 out of 20 statements were agreed on, and we're talking about 52 experts. So we still don't have a good definition of breakthrough pain. The best way that I can read breakthrough pain was exacerbations of pain, regardless of if the patient is receiving underlying treatment or is not. So exacerbations of pain. The idea of pharmacological treatment for this would be medication with rapid onset, short duration, high potency, and high bioavailability. From this, the oral transmucosal drug delivery is favorable for many reasons that I already mentioned: high vascularity, lipophilic, and the route of use. Some of these advantages are mentioned before. Patients with dry saliva, and patients, they might have, a lot of the patients have actually this, dry saliva and difficulty to administer the medication. So that's an inconvenience for patients that are too sick. Probably it's not going to be a good alternative. But however, the sublingual tablet seems to be a better option. The patient doesn't have to be able to hold the lollipop or to apply the spray on its own, and probably that will be the best option. So from all of those options, the sublingual tablet was the better tasted. It was still efficient, and in comparison with the oxycodone that it was mentioned before, it was a good product. So I think I'll leave it with that, and then if you have any questions that I can answer.
Okay, Okay, thank you, Dr. Rodan, for the perfect lecture that we learned much more about the breakthrough pain and new medications. And this morning looked like we learned a lot about new opioids. It's just not only morphine anymore. Each kind of opioid is like a different kind of animal. They have their own property. But for now, anybody have a question for Dr. Rodan? But for Spanish speaking, I think it's just perfecto. That means it's just perfect. Yeah. So, Pinut.
Any kind of sublingual, or do you recommend to using fentanyl patch IV form, put in the patient mouth and then try to be absorbed as a sublingual?
That's a very good question. I think the product is made completely different. The technology is completely different, so I don't think that will apply. But it's interesting that some of our drug addicts in the United States, they have tried different things like chewing the fentanyl patches. I seen the people that were blending it, just putting maybe making a smoothie with the fentanyl patches. So people can be very creative. I don't know if that would be an alternative. What do you think, Dr. Ha? Maybe something to try.
So if you put the IV into your mouth, it's not going to get absorbed because it's in chloride form, so it's water soluble. Okay? It has to be fat soluble in order to get absorbed in the mucosa. Okay? Also, one of the pitfalls of this rapid onset fentanyl is patients tend to develop tolerance rather quickly. So we have a lot of experience with the fentanyl lozenges, which is also called lollipop. When we start out with 200 micrograms, they have access to this because they can use it as needed. So if they freely have access to that, they just gonna reach for it anytime they're hurting. Okay. Now what that causes is tolerance. Okay. Now 200 microgram lollipop is no longer effective. Okay. 1 week later, it doesn't work for them. Now they go to 400. Okay. 600. Go all the way up to 1,200, rather quickly. Yeah. So that's why this is really limited for the cancer patients with a limited life expectancy. Okay? So because they do develop tolerance, and then these are very expensive. So you have to be really judicious when trying to use this for the patients.
Yes, in respect, my experience with these medications is pretty much inside the hospital. I haven't prescribed to any patient. I'm not too sure that I will, but I have used it, and it's been a good resource in some of the cases. Patients with no IV access who need a rapid onset of analgesia, patient who's in the radiation department getting radiation and has to stay in certain position, and they have a lot of pain. That probably be an option. Patients need to get an MRI and they have a severe back pain from metastatic lesions. I have used it in some patients in the hospital with rectal cancer and very painful bowel movements, so they have used it for that reason. And also in my procedures, a lot of our patients were doing a splanchnic and nerve block, and they had to lean in their stomach where the tumor is, so they have a lot of pain. So one option is just to medicate them with a lollipop of fentanyl, and has been very effective as well. That's an experience.
And sorry, Ajahn, for the laugh, but I think the reason we laugh because we all experience that some of our patients abuse the fentanyl that way. They just put underneath the tongue, and then sometimes they try to chew it to make them high.
Does it work as a lingo?
No. Yeah, that's right. Sometimes they just crush oxycodone and snort into the nose. They have many ways. I don't know if they can do it by ear also, but they have many ways to abuse it. Okay, look like we have one more question. Okay, by Dr. Pramod.
I'm Dr. Pramod. I would like to ask two questions for you. I haven't used this one before, so I have less experience. One thing, it seemed to be very good for the acute post-op pain or not, I'm not sure. Are there any study for the acute post